Hello, everyone. Good afternoon, good morning, good evening from wherever you're joining in from. I'm going to ask my panelists to please switch on their videos. We now have the green light to start our panel. I was just waiting to hear back from Emily if we can start. So I think we can now start. Thank you. I see Grady. Hi, Manisha. Helena, your video is still off. Yep. Great, great. Thank you. Thank you, everyone. We are so delighted that you could join us today for this panel conversation. My name is Koi Mariah. I am an Aspen New Voices Fellow, 2021 cohort. And we are so pleased you could join us for this panel conversation today. And we have a great lineup of panelists. So I guarantee you that it'll be an awesome conversation. So please feel free to drop any questions that you might have in the chat function, and we will try and get to them towards the end of the session. But just as a way of kind of setting the scene for this panel, right now, many countries are facing humanitarian crises that have been made much more complex by the COVID-19 pandemic. And this has kind of marked a disruption in sexual and reproductive health and rights. Women and girls in crisis situations face increased risk of sexually transmitted diseases, including, for example, HIV/AIDS, unwanted pregnancies, child rape, forced marriage, maternal death and illness, and sexual and gender-based violence. And all of this is happening in the broader context of inadequate systems to respond to their urgent needs and help them cope with the aftermath of all of these crises. So this panel today brings together advocates, scholars, and practitioners from affected communities to discuss the challenges in prioritizing sexual and reproductive health in responses to humanitarian crises. And the panel will also share lessons for more comprehensive responses that center the voices and needs of communities in crises, meet urgent needs in SRH, but then at the same time, strengthening systems that enable redress and prevention from further harm. So what I will do is I will introduce my panelists as we go along rather than kind of introduce them all at once right now. As I kind of pose a question to each of them, I'll give a brief introduction and then I'll ask them to tell us more about, their reflections or more about their work or what they do. And to the panelists, just a reminder that we will be quite strict on time. And this is not to stifle anyone in any way or to stifle the conversation in any way, but rather because I would also want us to have a few minutes at the end of this session to engage with the audience and interact with the audience and kind of have a chance to answer some of the audience questions. So please bear with me if I sort of, interrupt you as you're speaking or anything like that, but I hope we wouldn't need to do that. So to start us off, I will start with Helena. Helena, welcome. So Helena is a gender researcher and consultant with an interest in African feminisms. She's the co-founder of Yellow Movement, a youth-led feminist movement coordinating advocacy and empowerment programs in higher educational institutions of Ethiopia. She's also a very strong advocate for sexual and reproductive health and rights of women in conflict zones. And like all of my panelists today, Helena has a very impressive bio. I would not be able to do justice to kind of the bios of all these panelists that I have today. It might take the whole session if I decide to read out their full profiles. So I do encourage you to maybe look them up on social media or on the internet and just find out more about their work and what they're doing. But so to kick us off, Helena, how has sexual and reproductive health been affected during the current crisis in Ethiopia, and particularly reflecting in the context of the current war that started in the northern region and has now advanced to other regions? Over to you, Helena. Thank you.
Thank you, Q, for that kind introduction, actually. That's more than enough. And thank you, everyone, for joining us. I'm just going to jump right into it because I know that I have 7 minutes allotted, and that's that. I think it's very important first, maybe, to break down the question itself and understand that it's a very politically compounded and heavy question, mainly because when you talk about sexual reproductive health and rights or services, as well as conflict, that both are politically loaded terminologies, depending on the context of the war and depending on the services that are to be provided. Specifically for the case of sexual reproductive health, I know that within the context of Ethiopia and the cultural and the political dynamics of it, who gets access, who's left behind, even prior to the war, is quite political. And it's to be decided by a very male-dominated political space that is not necessarily inclusive and reflective of the experiences and the rights of women. And therefore, that too has its own politics and baggage that comes with it. Same for the conflict as well. in light of the conflict that started in Tigray and now is all around the country, and is affecting different communities in addition to the grand communities in the country, that you can look and have a look at the context of the war and see, how it's defined, the intensity of the war, and also the nature, the type of the war itself defines the kind of urgency that's thrown out in the world and how international community and actors respond to it. And it's not just it's not just particular to Ethiopia. I think it's common all around the world. When you look at countries such as the Democratic Republic of Congo, the South Sudan, Yemen, Myanmar, Colombia, all these countries have faced different forms of violation targeting the rights of women, the rights and health of women, and the very definition of the war itself. The type of war. Is it sexual violence as a weapon of war? Is it sexual violence as genocide? Is it sexual violence as ethnic cleansing? All that defines the scale of the response that is geared towards that particular context. So it's really important to understand that war is complex in Ethiopia, for Ethiopia, but for the rest of the world as well. And the concept of sexual reproductive health itself is quite complex and political in itself. And unfortunately for women, in both spaces in the definition of the political terminology, it's very unlikely for a lot of women to be involved and to add their experiences within the the very definition of what qualifies as such, and they're impacted by it immensely. So I'm just going to start with that. The second bit and portion of my answer would be, I think, as a lawyer and as someone who's a big fan of the CEDAW Convention, the Convention on Elimination of Discrimination Against Women, General Recommendation 24 sets a standard on how we should understand the lives and experience of women when we're talking about sexual reproductive health. That is, women face all ranges of violations, all ranges of health problems, depending on their age group, depending on their life cycle. So the life cycle model is very much core to how we discuss what are the needs of women. So, for example, we can identify them in four groups: infancy to childhood, the kind of violation that women face, the kind of sexual and reproductive health needs that women have, or girls have, between the age of 0 to 9, between the ages of 10 and 19, between the ages of 20 to 44, and 45 above, are quite different because the range of violation that they face is different as well. For example, for adolescent girls in the context of Ethiopia, you can see that within the context of war, it's common to have a number of girls that are assumed to be virgins being targeted by rape. Being targeted by systemic and widespread form of rape, because it's a form of shaming communities as well. So when you're raping a girl that is, underage, that's considered to be a virgin, chastity is a big element of it. So you're not just passing the message through her body, but it's also a form of communicating the form of violence that you want to impose on that community through her body. So it's quite complex. It's not just about her, it's also about her community. Quite unfortunate to be saying this. And so forced pregnancy, forced early marriage, although they have many things in common between these age groups, there are some things that are also very particular. Especially women in the elderly age group also face a very specific violation, and they have a specific need, sexual and reproductive health and needs, which typically is ignored because they are considered to be outside of their reproductive age, and their needs are typically not considered within humanitarian responses. So it's very good, and it's best to assume our responses within that line. And speaking of the particular context of Ethiopia, again, starting from Tigray, but the war that has now affected communities all across the country, including parts of Oromia, Afar, and Amhara, as of late. The conditions were not obvious at first, but as war, we know war typically affects women, because what happens is whatever gender inequalities that we've had prior to the war is just an extension that will be extended, magnified even so during the context of war. So you cannot assume that any side during the war is, ethical or right, because those violations are meant to communicate a bigger message to the community, not just to the individual women. Quite unfortunate of a tactic that has been used in the past and will continue to be used as well. So this context is continuing to happen. We still have an active war in Ethiopia that's affecting many Tigrayans in the country, predominantly, but also affected different communities that have been listed earlier. And I guess within the weeks, the very early start of the war is when we started discovering that there was a deliberate deployment of rape, sexual violence, and as I've stated, attack on chastity of women, which was supposed to be a means of communicating whatever sorts of grievances that other parties had, and kind of collectively dehumanizing and defiling at large. And it meant a lot to that context as well. And the violence of penetration itself was very particularly grim because it involved use of hot rods, dirt, insertion of condom inside a woman's body, intended to permanently damage sexual and reproductive function of the women collectively. So that was quite a sad scenario to start with. So with that, you also have to understand that Ethiopia is a poor country and poverty is already there, and it already has a weakened health system even before the crisis and the disaster itself. And therefore, whatever is happening today, whatever I'm going to be discussing is just an extension of that, and an even worse scenario of that, because health infrastructures, particularly health infrastructures within these regions, have been affected by the conflict itself. And therefore, the areas of engagement and the things that many communities, many international organizations, but also local organizations that are working on the rights of women, the sexual and reproductive health and rights of women, have been focusing on first preventing and managing the consequences of that sexual violence itself, with the assumption that no group is ethical, and that more often than not, experience of women across the country can be the same. It might be different in terms of the scale and who's involved and to what extent, but really women's bodies and women's experiences have been subjected to, sexual violence at large. So that's the common thing that we've been trying to work at. And another problem with that, with the prevention and managing of sexual violence, is all sides tend to neglect that agenda. All sides tend to tell you that this never happened, including the government outrightly would deny circumstances of sexual violence initially, and then you have to push further for you to get the information. So that denial also somehow raises the experience of women, and that has been common with Ethiopian government or other governments that have been involved in the context of the Ethiopian war as well. Quite unfortunate. And then the second one is the reduction of the transmission of HIV/AIDS. Again, that was later on admitted on the part of the government, but transmission of HIV/AIDS systematically has been used against women of Tigray in particular. And with that, there are different organizations that are working towards reducing that transmission rate, as there are still soldiers present in different corners of Tigray today, local forces, international, outside of local forces as well. And so even getting treatments that are, important for this, like PrEP, to minimize pre-exposure, but also to continue to treat people with HIV/AIDS has been quite hard, because humanitarian access to Tigray has been completely blocked, and there are no more help coming in, and that has made it quite difficult for sexual and reproductive health rights to be practiced within the region. So that is one major issue that's now hampering the number of activities and initiatives that are geared towards servicing the rights of women. All right, great, thank you.
Yeah.
And the third part of the service would be preventing maternal and infant mortality. Again, because of the conditions, lack of nutrition, among others, that women are forced to carry the babies that they don't want. And when they do too, then safe birth is not guaranteed. And in particular, I want to highlight on the role of international organizations coming in, especially in the provision of abortion. Many of the women who do not choose to carry these babies do not have the option of having safe abortion. And that's mainly because many of the organizations, again, coming in, tend to be faith-based organizations, although Ethiopian law is clear that these women have rights and access to this, but the faith-based organizations that are operating in the region of Tigray, and regions other than Tigray as well, Oromia, Amhara, Afar, have been having a hard time providing that service just because they are oriented in a different way. So faith gets in the way at times. And then the fourth one will be a plan to return to comprehensive services the way that it was prior to the war, which is quite difficult. I mean, we can talk about a number of things, but I'm just going to mention one instance of it, which is not just the idea of comprehensive health service is not accepted. Comprehensive sexual health service is not accepted within the legal ambit of Ethiopia. And so because of that, people of different sexual orientation, and even men that are affected by this in the country will not be having services that are needed during this humanitarian crisis. And that's quite unfortunate again. Thank you.
Thank you. Thank you so much, Helena. That was very powerful, very passionate. Really sad, actually, listening to you talk about, the use of rape as a weapon of war and the symbolism around it. And I hope we can get a chance to maybe unpack some of that as we have a discussion and question and answer later on. But thank you for that very powerful delivery. Very sad to listen to, but thank you for that. So next we will have Manisha. Welcome, Manisha. So Manisha Kumar is the head of the Safe Abortion Care Task Force at Doctors Without Borders. Manisha's background training is in family medicine with additional training in public health and obstetrics and maternal and child health. So Manisha, the question I'd want you to reflect on for this panel today is: in humanitarian crises, sexual and reproductive health needs like safe abortion care are often overlooked. Based on your experience, what are the challenges in prioritizing SRH in response to humanitarian crisis? Over to you, Manisha.
Thank you so much. And I just want to start off by saying thank you for inviting me to join this panel. Kind of piggybacking on what my co-panelists did, I also want to kind of break down the question itself and the phrases we use, because we often talk about SRH, yeah, or sexual and reproductive health, as if it's one thing. But really, sexual and reproductive health is a package of services, of so many different services. Um, and so when we're struggling to provide this package, I think within that package of sexual and reproductive health, different components and different activities are treated differently. And so I want to focus a little bit more on contraception and safe abortion care. But I just want that understanding that sexual and reproductive health as a package, it really encompasses a broad array of services. So antenatal care, safe delivery care, postnatal care, STI testing and treatment, HIV testing and treatment, sexual violence care, safe abortion care, contraception. I think in general, these services are deprioritized or not prioritized, if I'm being very frank and very honest, because they're not seen as essential. And I think lots of times that's because the people who are most impacted by the lack of these services are women, and they are already marginalized in their societies, in their community, in the world prior to the conflict or the crisis even beginning, right? And in a lot of places in the world, I think we're kind of beyond the point where we see it as everything was fine and then there was a crisis, right? But it's really about crisis on top of crisis on top of crisis, right? So you have chronic conflict, and then you have an acute exacerbation or acute conflict on top of that. So there's just so many layers to humanitarian crisis now, that I think that further complexifies our humanitarian response. Um, so yeah, they're just not seen as essential services, period. And then within that whole package of sexual and reproductive health care, I think certain services are even more relegated or deemed less essential or like optional services. So that includes contraception, although I know a lot of people use the phrase family planning. I prefer contraception because I find it's more inclusive. There's a lot of people who need to use contraception for a wide variety of reasons, including to prevent unwanted pregnancy, that aren't necessarily trying to plan a family, right? Particularly young women who want to stay in school, or older women who need to continue working. There's different reasons behind needing to prevent unwanted pregnancy. And then also safe abortion care. So my co-panelists touched upon it briefly at the end, so I want to expand upon it. I think a lot of humanitarian organizations are really reluctant to provide and prioritize contraception and safe abortion care in particular. One, because they're not really seen as important or essential as other services. And I think it's also because they have a lot of internal barriers. So she mentioned faith and religion. So absolutely, if you have a lot of faith-based organizations coming in and they're providing the majority of their aid, their own personal values or beliefs are going to bias the care that they're providing. I think even for larger INGOs that aren't necessarily faith-based, there's a lot of reluctance to talk about abortion in particular because it's such a taboo subject, and also because people make a lot of assumptions about the legal framework in the context, what's culturally accepted in that context, what people are already doing. So in reality, we know that abortion happens everywhere, all over the world. Also in crisis, in times of non-crisis, in conflict, in peace times, abortion happens by people everywhere. It's one of the most common procedures that someone can undergo. Um, And so I think there's a tendency in these organizations to often see the community as a monolith. And when they want to engage with the community, they're often engaging with older male leaders who are traditionally in power. And so they're not really getting to those who are the most vulnerable, who are the marginalized, who are in need of these services, and are already probably to some extent accessing abortion. It's just that they're accessing unsafe methods of abortion. So unsafe abortion is one of the leading causes of maternal death and suffering worldwide, and it is the only one that's almost entirely preventable. So when people restrict access to safe abortion care, that is when they are forced to resort to unsafe abortion. So this is just to highlight that whenever there's a lack of care, communities are very creative and people are very creative, and they will find ways to try to compensate for those gaps in the system. And I think that traditionally, the humanitarian organizations have seen those people um, and tried to discount them and said, we are the only ones that can provide adequate health care or adequate services. But what we really need to start doing is to start saying, how can we partner with those people? How can we partner with traditional birth attendants, local healers, people networks that are already there and existing in the community that are already, were trying their best to make up for this gap and lack of services? And how do we support them to be able to provide this care themselves and make those bigger networks? With MSF, specifically Doctors Without Borders, or Médecins Sans Frontières, the humanitarian organization that I've been working for these past few years, a few years ago, we started the task force because we identified a lot of internal barriers to ourselves, why we were not providing safe abortion care more regularly in the places where we were working. It was really easy to point outside and say, oh, it's because the legal framework, or oh, it's because the community won't accept it. This culture is too conservative. But we took the decision to look inwards and do some pretty difficult but important self-reflection work. And we realized that those internal barriers were things like personal values and attitudes, our own values as an organization, stigma, the marginalization of women, lack of information about abortion care, lack of understanding how it's an essential healthcare service. I think because abortion is so politicized, it's often seen as a political or legal issue. On the other hand, family planning is often talked about for its social benefit, right? Or contraception. So we don't necessarily see it as healthcare, even though it is. And so we developed a whole package of tools and approach to tackling these internal barriers. And what we saw as a result was 100-fold increase, multiple 100-fold increase in the amount of safe abortions we provided worldwide. So it went from 781 abortions in 2015 to over 30,000 abortions provided in 2020. And I just want to say that all of that was due to internal work. So I think there's a lot of work that humanitarian organizations and the humanitarian context needs to do internally. Nothing changed that dramatically across the world in terms of the landscape around this issue. It was really the organization deciding this is a priority and we are going to tackle this. But we have not done enough. The changes that we've seen have happened in the countries where we've really invested a lot of heavy resources and support to provide this package. What's needed is more of an integration, I think, across the entire humanitarian organization sphere, right? And the final thing I want to say is that ultimately, I think if we're going to see SRH start to be prioritized in our humanitarian response, and particularly safe abortion care, I think it's going to require a major shift in the way that humanitarian organizations conceive of the aid that they're providing, of the services that they're providing. It's going to involve a major power shift. We're going to need to become better listeners. We're going to need to become better partners, and we're going to radically trust. We're going to need radical trust in the people who we say we are trying to help. We need to trust them, that that they know
Mm.
what's best for their lives, that they are the experts in their lives, that they know what they need. And our job is to listen and support them to get that.
Thank you. Thank you so much, Manisha. And I think everything you've said really ties in well with like the overall theme of this event, like invisible no more. I really like that you reflected on how aid agencies sometimes can invisibilize, certain important actors in the community rather than partnering with them. But also as a qualitative researcher, I'm very much into kind of reflexivity. So doing internal work, even just as an individual. So I really like that you're talking about even institutions and organizations doing that internal reflection, constant reflection. How can they do better? And not necessarily coming in as, oh, we're the experts, we know what is best, and so on and so forth. So thank you very much for that. Grady, over to you now. So Grady is a legal researcher at the Center of Reproductive Rights, a global human rights organization that uses the power of law to advance reproductive rights as a fundamental human rights around the world. Grady leads interdisciplinary work examining how strategies and interventions grounded in international human rights law can strengthen rights-based accountability for sexual and reproductive health and rights in humanitarian situations. So Grady, the question I'd want you to reflect on today is, if you reflect on your experience, particularly in Uganda, what are the challenges in balancing responding to urgent SRH needs during humanitarian crises, while at the same time trying to strengthen systems for harm prevention and redress? And before you answer, I just want to acknowledge what Manisha, started off by saying, that we also need to problematize this thing of kind of just talking about SRH and understand that that is such a huge word and encompasses so many things. So Manisha, I acknowledge that, and thank you for pointing out that to us. But all the same, Grady, I'll let you reflect on that question. Over to you.
Great. Thank you, Koi. And yes, I think that what I'm about to share flows really well from what Manisha and Helena previously spoke to. So it's great to be with everyone. Thank you so much for this really kind introduction. I'm quite honored to be speaking on this panel and having this discussion with everyone today. And as we've heard, I don't think I need to set the stage. In my work and in the work we've heard so far, lack of accountability and lack of remedy and redress for sexual and reproductive rights violations remains a key feature across all humanitarian settings. And we continue to see states really fail to prioritize SRHR fully and fail to prioritize them within the full scope of their existing human rights obligations. So these are obligations and responsibilities held by duty bearers. And in deeming these, services non-essential or deprioritizing them, despite really clear evidence that we have, and I think this speaks to Manisha's point about sort of the broad range of SRHR, and we can look to evidence-based guidance, like the minimum initial service package for reproductive health, the MISP. I'm sure many of you are familiar with this. And this is a body of evidence that sets out the response to SRH needs within the first 48 hours of an emergency. And yet we know in so many cases, the full provision of the MISP is not up and running within that time frame, and the movement to comprehensive care isn't something that's fully realized. So we know, and we've heard a lot about this today, some of these practical challenges associated with holding health systems to account in particular. And this results, from breakdown of health infrastructure, fragmentation of SRH services, across the response. But at the same time, we also see access to justice and traditional accountability mechanisms being made even more inaccessible in humanitarian crisis. And what has been spoken to already, and I would agree with and just want to emphasize, is that indeed a number of these crises and breakdowns existed prior to the conflict or the crisis. And so we're working within a compounded setting. And these things, in terms of legal accountability, we're looking towards national courts, tribunals, the work of paralegals that often work in mobilized settings when we think about humanitarian or fragile states, but also administrative accountability mechanisms that are important for SRHR, like maternal mortality audits or morbidity reviews. And in this context, of challenges, like you've asked me, Koi, I think it's important to remember that human rights, including all the rights that are contained under SRHR, apply in all settings and at all times. And so these continue to apply in humanitarian situations. And often in our work, we hear that it's just not realistic to apply human rights, or that it's too difficult to do so in humanitarian settings. But I think it's in these settings where human rights are most needed. And we actually have evidence where that can work, and have provided that evidence really to combat some of this misinformation and misconceptions about human rights in these settings. So while it's really important to note there's some really critical ongoing work to address the gaps, to address legal accountability for SRHR violations, which Helena spoke to. Given today's discussion and our focus on our SRH services and delivery of care, I'll be sharing some lessons from the work that the center's collaborated on with our partners at Care Uganda. And this work really tries to pull these standards, down to the ground and understand better, because we don't have a good understanding of how the application of a human rights-based approach within the humanitarian program cycle, at least as it relates to the delivery of SRH services and information, can in fact strengthen and hold health systems to account, and to account to access and making sure that these essential and life-saving services are provided within the full contents of the right to health. So what does this work in Uganda look like, and what was it able to realize during the project? So we worked with women leaders from women's refugee welfare committees, local councils and village blocks in Ajimani district in northern Uganda. And the goal was first to really understand better, what is it about existing accountability mechanisms? So things like hotlines or complaint desks, feedback boxes that are traditionally used in some clinic settings and mobile settings. What about these mechanisms actually create barriers or are ineffective at remedying SRHR violations? And we worked in partnership to conceptualize what structures or systems could look like to support a more enabling environment for refugees from South Sudan and post-conflict affected host women and girls from Uganda to claim these rights and actually be able to demand remedies and structural change from the humanitarian and host health system. And this resulted in the establishment of a rights-based social accountability mechanism that was led by community women leaders and representatives from adolescent and disability solidarity groups. And they were mandated to collect and review SRHR complaints from the community, and then to work with an independent third party who translated and worked with duty bearers, both state and non-state, to actually ensure that availability, accessibility, acceptability, and quality, all core components under the right to health of these SRHR services, were provided as an effective remedy, right? So structural change as an effective remedy. And given the stigmatization of SRHR that this panel has so expertly highlighted already, and the discrimination that marginalized people especially face while accessing SRH services, in addition to the risk and repercussion for speaking out against a system that provides the most essential needs for displaced populations and has intrinsic power asymmetries, confidentiality and working with these intermediaries really was an important element, if not the most important element, to women and girls for this concept to work. And I highlight that because I think there's a lot of synergies in existing work in humanitarian settings where we can do a better job of working with these kinds of intermediary models. And these structures focused through their mandate on intersectional discrimination that really further marginalizes certain groups of people and shapes certain access barriers. And on behalf of our team today, I'll share some examples of the remedies that the accountability mechanism was able to realize just over a one-year period. And in one example, it included revising clinic scheduling, something, as simple as that, revising the policies so that it incorporated an adolescent block where confidential services and contraceptive counseling were available and reserved for young persons. And that came out of numerous complaints related to their rights to privacy and confidentiality. And in other examples, the accountability mechanism guided changes to humanitarian actor policy and practices. And this is in line with a commitment to guarantees of non-recurrence. So putting in place measures to ensure that the harm or violation that's taken place does not happen again in future to others. And these examples included mandating things like respectful maternity care trainings for humanitarian staff to address reports of mistreatment and discrimination during delivery services in particular. And in another case, a remedy included oversight. to improve referral pathways between health and protection systems. So survivors of sexual and gender-based violence reporting to this community mechanism were accessing comprehensive SRH and GBV services, including comprehensive psychosocial care and access to justice. And so this is just one context-specific example. And I think when we're talking about these settings and we're talking about human rights-based approaches, it's a truism, but context is everything. But I think what it does is it gives us an example, a starting point anyway, of what implementing rights-based accountability to ensure access to services can look like. But I think more than that, this study also importantly challenges this misconception that human rights-based responses to humanitarian situations, lead to some kind of ineffective humanitarian response. When in fact, what we're finding through this work is, not only feasibility, but also high acceptability among humanitarian actors in this context to have those reflexivity, assessments and positionality reviews, and to kind of integrate these mechanisms into their routine service delivery as one, but also coming to the table to think about and discuss these really complex questions when we're talking about accountability. So I think we need to see more of this kind of integration and implementation of human rights-based approaches really as a central part of the humanitarian response, from all the way from planning and preparation, certainly as a way to strengthen protections for rights violations, but also as a way to ensure access to meaningful and transformative remedies, which have to include access to sexual reproductive health services and information.
Thank you, great. Thank you so much. I see we've gotten a 10-minute warning. I'd said earlier I'd be very strict on time, but some of the stuff being discussed is so heavy. It's difficult to kind of interrupt someone when they're talking about something so powerful and so heavy. So I wasn't as strict on time as I'd said I would be. There was a question about centering the voices of women. Helena, I'll give you a couple of minutes to just speak on that. But before you do that, to the Aspen team, I see Pashtana is in attendance, but I can't see her video, I can't see her audio, so I don't know if you can rectify that. So maybe Helena, you could just very briefly reflect on the question around sorry, just give me a second. What does centering voices of affected women and girls look like when responding to humanitarian crises? If you could just answer that in 3 minutes or less, and then we'll do a quick spitfire of recommendations from all three of you. And then if we're able to get Pashtana's video and audio, she can finish up for us with a question around hope, because a lot of the things we've discussed today can frankly leave one feeling a little bit hopeless. So it'll be good to kind of end things on a positive note. But Helena, over to you. What does that look like, centering the voices of kind of women in affected communities?
All right, great. Thank you. I would say two things. I'm just going to focus on two things. One is that it has to be intersectional, as in whatever community that you're working on, you have to make sure that it's not just addressing communities considered as mainstream. And again, within the particular context of Ethiopia, you have to take considerations such as ethnicity, age, socioeconomic background into consideration prior to providing the information and the services that you intend to provide, because it's completely a different situation if you don't center it around ethnicity and all that, because those are really important factors. And the second one is budget. Again, I think putting your money where your mouth is, where your heart, your passion is very, very important. We hear a lot of big talk within international conferences, gatherings, that such and such is to be done. But I guess it's not necessarily focused on the experiences and the needs of people within this house. And I can I cannot speak for the whole continent of Africa, of course, but I know within the context of Africa, predominantly, that's the case, that it's not necessarily funded well. And it's assumed that within the small budget that miracles can happen, but truly that's not the case. If you want a comprehensive form of support and service, you need to fund it, and you need to fund it right, and you need to fund it in a way that centers the experience of people from all forms of community, and has to be informed by gender practices of intersectionality, which I think should be at the very core of it. So when you provide, of course, it has to be dignified, it has to be safe, it has to be consent informed. Another huge problem with international actors coming in, has to be consent informed and has to be done in a confidential manner. Thankfully for all of us working in this space, there are so many guidelines that we can look into, including the UN Security Resolution 2467 and many, many others that are really making it important for it to be dignified, safe, consent informed and confidential. That's what I'm going to say, but money is really important.
Thank you, Helena. Manisha, you are nodding so much. I just have to ask you to just give one point in there. Just throw it in real quick because you are just like,
One of the things I've been thinking about this whole discussion is really, I think what we're dealing with is right now we kind of operate in the scarcity model, right? So in the whole big budget, people give SRH like this little slice of the pie. And they're like, all the woman things, put it in that, right? That's where all those things go. And I think we need to problematize that and say, no, we need to demand that space. We need to demand that that little slice becomes much bigger. We're half of the world's population, right? So, and that's even taking a very narrow view of gender, right? And so I think that we need to kind of get out of this scarcity model where we're fighting for a seat at the table, or we're all competing against each other for the same slice of the pie, right? And start asking, why don't we have a bigger pie? Why aren't we having bigger budgets? Why aren't we having more resources and more support?
excellent. Thank you very much. Grady, is there anything you'd like to add to that, or can I go to the kind of quick fire round of recommendations?
I'll just really quickly add that a lot of the reasons we were able to problematize the questions that we did in Uganda was because we had flexible funding to do so. And I think it would have been really difficult because there was so much adaptation involved that we wouldn't have been able to do without that. So just to highlight a concrete example of what that can look like when we have those funds available.
Thank you. Thank you so much. So I'm going to give each of you a minute and a half because we've already gone over time. So you were supposed to have 2 minutes to give your kind of parting shot, but I'm going to reduce that to a minute and a half. And I'm going to ask each of you to kind of reflect on what would be the one thing you'd recommend for humanitarian responses to adequately balance meeting urgent and immediate and very real needs, while at the same time strengthening systems for accountability and prevention of harm. So maybe I'll just kind of go in the order that you were talking. I'll start with Helena, a minute and a half, then we'll go to Manisha, and then to Grady. Helena, over to you.
I'm not sure if it's going to be done immediately, but I think focusing on data and understanding there is a data gap anywhere you go is very important. I think that's one thing that's been left completely. So when you're responding to community, make sure that you look into the data that's already within the country's framework, within the national framework, and that's quite important, I think.
Thank you. Manisha?
Mine is also really quick. I have two things. One is talk less and listen more. And the second one is trust. We need to trust in the people that they know what's best for themselves.
I
Radical
love that.
trust.
Yeah. Music to my ears. Listen more, talk less, and trust. I mean, as someone who's based in sub-Saharan Africa and kind of observing many of these things, that is, and someone who's been very vocal in the decolonizing global health movement, I really strongly kind of agree with that. Grady.
Yeah, so I think, the most important thing for humanitarian actors is recognizing what, when we're thinking about accountability, that in fact, these are mutually reinforcing notions, right? Systems of meaningful accountability and meeting needs and rights to essential SRH services. And what I think that looks like is just implementing human rights-based approaches and the standards, like CEDAW General Recommendation 30, like Helena raised, WPS agenda. I mean, we have these standards and we have this guidance, and I think it really comes to implementation of them. And it's an imperative, especially if we're going to take decolonization seriously and localization seriously, to center affected persons and their full, effective, and meaningful participation at all stages of the humanitarian response. And I think that is, especially for those who are most disadvantaged and marginalized by the situation or event. But of course, there's pre-existing root causes of inequalities and discrimination that affect all women and girls in all of their diversity. And that is before the onset of the crisis itself. So a much more holistic picture.
Thank you. Thank you so much, Grady. Can someone from Team Aspen let me know if we're able to get Pashtana's audio and video? And as we're doing that, I see we have a couple of questions in the chat from Emily. So I wonder who to give this one to. Maybe Manisha, because I think you kind of touched on this a little bit. So the first question from Emily, she's wondering what advice you'd give for well-meaning but maybe misguided allies who want to help in crisis but don't know how to, or but don't know how more. I think, but don't know how. What would be your advice? So well-meaning allies. I mean, I think you kind of touched on it with the idea of trust, but maybe you could unpack that just a little bit more in like a minute. Yeah.
Yeah, and maybe I can also pack that on to her second question, about like the Red Cross and how do you know what organization to trust, right? Because my answer to the first question is what can you do when you're well-meaning? I really think it's about um, one thing you can do is donate and fund and support smaller grassroots community-based organizations who are on the ground doing the work that you believe in and that you want to support. Um, and I think yeah, it's hard. I mean, I work for a large INGO, but I think that if we want a change in those power dynamics, there ultimately has to be a change in the way that money flows, right? So it can't be given to these INGOs to then give to community-based organizations. The money needs to start coming from the ground up. And that's one thing that you can start doing. And do your research, do your homework like every organization is different. Every organization has different priorities. They talk about different topics or different things that are important to them. Like identify the organizations that are important to you or the topics that you feel the most committed to. I sound like a fundraiser now, my goodness. But then my final thing was to be a regular donor, be a monthly donor, because a lot of these smaller organizations, right, what they're really looking for is more regular funding streams. Right. So having a one-time big donation is not as useful as having a more regular, smaller donations.
Thank you, Manisha. Before I give maybe Grady and Helena a chance to reflect on any of those two questions, I'm going to play devil's advocate here on what you've just said. So I'm very much also an advocate for kind of bottom-up approaches and funding kind of grassroots organizations directly. But what about sometimes some of these organizations may not have the capacity to kind of manage and handle those funds. So what do you say to that? Because then I feel sometimes we might be setting them up for failure, and then we're like, oh, see, we tried the bottom up approach and it didn't work.
No, you're right.
So
You're
yeah,
right. No, I guess my point is like the big NGOs, they'll still get a lot of the money. I'm not really worried that all of a sudden, these big INGOs are going to collapse because there's going to be this huge movement of support for community-based and grassroots organizations. I think it's about re-equilibration, right? So the INGOs have their role, and these smaller, more grassroots community organizations have their role to play as well. And it's just about shifting that power or making a more even playing field or just redistributing some of that balance. It's not about that the role of INGOs would therefore be is there's no role for INGOs anymore.
thank you. Thanks for that. Grady, and then I'll go to Helena. Do you want to reflect on in any of those two questions that Emily raised in the chat function? I trust you can see the chat function. So one was about well-meaning allies, and then also about how do you know who to trust when what is your advice on direct assistance where it'll go to support the sort of SRHR friendly assistance that is most urgently needed?
Yeah, I think to the point, that you made, Koi, about how we work, we're always working in partnership, right? And I think we need to position these kinds of interventions, even in humanitarian situations, within the broader scope of social movements and social movement building. And certainly when we're working with grassroots organizations, we're also working with researchers. We're also working with legal advocates and advocates at the global, national, regional level. And so I actually think it's through those kinds of partnerships that we can actually address a lot of the challenges and realize a lot of the solutions that are being set by an agenda from women and girls on the ground. And in the model that we use, we conceptualize it as a circle of accountability. So really using, the data that's generated on the ground and through these interventions to inform the advocacy that we're doing at all of these different levels. And hopefully by setting more progressive standards at those levels, that translates back into what we're realizing in interventions in humanitarian settings, but across settings. So to me, conceptualizing it as a circle of accountability through funds, through interventions, through programming, through evaluation and learning, I think that's the most productive and progressive way forward.
Thank you, Grady. Pashtana, good to see you. I'll come to you in a minute. But Helena, any final reflections on either of those two questions before I introduce Pashtana?
All right. Secondly, some of the points I suggest we go in and you understand the community itself and not necessarily assume things from particularly a Western point of view. And I think it's really important for you to directly engage with the community, because there is so much that's misunderstood within the general international framework, but also so much that's lost in media propaganda that's not well understood. So I think go see it for yourself and then assess and then conduct help after that.
Thank you. Thank you so much. Pashtana, welcome. So lovely to see you. So lovely that you can join us. I was a bit worried we wouldn't be able to kind of hear your voice or see you. So I'm really glad that you're able to join us. Thank you so much to my three panelists. But now to wrap up this session, I'd like to introduce Pashtana Durrani, who is an activist, an educator, an innovator, and a writer. She's also a community development expert and the founder and executive director of LAN Afghanistan, a grassroots level nonprofit. Pashtana is also a global youth representative for Amnesty International, Malala Fund education champion, and contributes to national newspapers such as Afghanistan Times and Kabul Times, in addition to doing so many other wonderful, wonderful things, which I would not be able to do justice in kind of describing it in a quick few minutes. So, Pashtana, as I kind of alluded to earlier, some of the stuff we've talked about is kind of very heavy, can leave one feeling a bit hopeless. Certainly, when Helena was talking at first, I was like, oh my God, this is like, it's just so heavy. Is there any hope for us? So, I want you to reflect on everything that you've heard from our panelists today, and drawing on your own experience with Afghanistan, where do you see hope for things to get better? Over to you, Pashtana.
Thank you so much for the kind introduction. Sometimes it's most of the things that you just said, like writing, it has been lost, but thank you for that. Yes, when it comes to sexual and reproductive health rights, it's a taboo topic in our society. I'm not sure about the panelists who have been working in it, but for us, it's pretty much taboo. Nobody talks about periods. Nobody talks about women getting pregnant until they can show. And even then, we don't refer to it until she has to go to the hospital. And if a woman is raped, it's barely even filed. The charges are never filed. So it's one of those things that you grow up with, and you can't reflect on it without getting hurt by the consequences. But overall, one thing that I have learned from the panelists here is, which is very true, by the way, I grew up in Pakistan. One thing I remember, all my cousins, all my family members, one of my aunt, they used to get abortions because they were married and they didn't want more children, and they used to get more abortions, and it was feasible, it was accessible. Half of the men didn't even know what was happening. They just used to go to the gynecologist, and it used to happen on daily basis. And all these organizations who used to work with, because the organizations were foreigners, they would go and talk to my uncles, or the old men, sort of thing. Then I came back home to Afghanistan, and even in Afghanistan, one thing I remember a lot is the fact that women do get abortions. It's the fact that we don't report it because it's a taboo thing, and in Afghanistan, because of Islam and religion, most of it goes unnoticed. So that is true. Who do you engage with when you as an organization go to this community and really want to help the people? Who are you engaging with? That's very important. The second thing is, most important thing is, how is your outreach going to affect them? Are you talking to the women? What way are you talking to them? Are you talking to the healers, the midwives in houses? I have found one thing very effective. Midwives are the best communication, because they are actually the ones who will be seeing the women. They are the ones who are providing them the drugs and everything. So that's very important. I myself have right now 2 doctors in Kandahar. I get updates every day, and they tell me every day, okay, this is prenatal healthcare checkup. This is postnatal healthcare checkup. We have referred them to this delivery section. We are referring them to this Planned Parenthood division right now, and that helps me a lot to understand, because I myself am an educator. I work more on education. But when you are educated on the ground reality that women do need abortions, even in a war-torn country like Afghanistan under the Taliban control right now, it does make you understand. But also at the same time, the fact that small organizations, coming myself from a smaller organization, they do need regular funding. You can't just give them one big chunk of millions of money, because A, they can't use that money properly. B, they need a regular stream so that they can continue their work without worrying for the money. Third most important thing, we have to engage with local communities by employing them. That's the most important thing. And I feel like the way the world has changed in the past 6 to 7 years, more and more people are becoming empathetic, but also at the same time, bigger NGOs are understanding that we cannot just send someone from the West with something like abortion to the East or to Africa or to Central Asia, places like that. And for that, they have to engage the local communities. They have to engage with more people. And I think that's something that gives me hope, because more and more people communicate, more and more people get to learn. But also, most importantly, women do take charge of their own bodies and take the agency of that, even if it's an abortion or a planned pregnancy. But at the end of the day, what sort of structures do we provide to make sure that is giving them the support that they need, even if it's a pregnancy or an abortion? And I think I would stop on that, because that's the sort of thing that we need right now.
Thank you. Thank you so much. And I think that's a great note to stop on. Women have agency. We shouldn't kind of discount people's agency, even people who we like to label as vulnerable and marginalized, that you also do have a sense of agency and autonomy. And we should never forget that. I'm really sorry we went about 10 minutes over time. The good thing is you have not missed any other session. We are going into the networking session now. I really strongly encourage all of you to click on the networking button. I think on my laptop, it's like on the left-hand corner, and you'll see there's kind of a red thing there saying now. So I really encourage all of you to kind of go into the networking session, get to meet a few of the other people who are joining this event. Thank you so much to all my panelists, to Pashtana, Helena, Grady, Manisha, all of you. Brilliant conversation. I really enjoyed it, which is part of the reason I did not stick to the time, because I'm like, this is just so interesting. We're just going to keep going. But yeah, thank you so much, everyone, and enjoy the rest of the event. Bye.